something else. So, Dr. Virmani, please.
Thank you, Dr. Arvind and the chairpersons. Uh, when you see a patient with diabetes, the first thing that comes to the mind of a clinician is how can I reduce his blood sugar to normal levels? And that brings me to the main and the only agenda of today's talk is glycemic control, the primary objective of diabetes management. I think Dr. Arvind knows very well that it is now mandatory to declare conflict of interest.
Oh, wow.
And in this, as far as this topic is concerned, I do have a conflict of interest which I'd like to share, and that is that conflict of interest is with the fake Babas who claim to have a cure for type 2 diabetes and who claim that type 1 diabetes does not require insulin. With these few words, let me tell you that it was in 1959 when metformin was introduced as an anti-hyperglycemic agent, but it was not till the 90s that it was approved in the United States. But we in India have been using it since a long time. When I started my practice in 1977, we were using metformin. And we had the first diabetic clinic at Tata Main Hospital in around 85, 86. And it was in 93 that the first guidelines came, and they were very simple. Start with metformin unless fasting sugar is very high. If that's not enough, add a sulfonylurea. And at that time, we had only glibenclamide and tolbutamide. And if that's not enough, stop them both and start insulin. It was easy to remember, but not patient-centric. Friends, that was me in 1977, and a lot has changed since then. And this is me in 2021. So what has changed? There is a paradigm shift in treatment from the classical triumvirate to a newer concept of homogeneous octet, egregious 11, filthy 15, the dubious dozen, and whatnot, where so many pathophysiological aspects are coming into recognition. From being glucocentric, we have become patient-centric, and we're heading to become complication-centric. There are a wide variety of therapeutic agents with similar glucose-lowering efficacy in the short term, distinct adverse event profile due to specific mechanism of action or potential off-target effects. Of course, I'm not including insulin in this. There are various drugs available that all of you are well aware of. Now, let me start with a typical case of type 2 diabetes that we see in our day-to-day practice. A 39-year-old male, breathlessness, ejection fraction 55%, 3 years duration, hypertensive, UACR 75, fatigue, and gets nervous during time. High BMI, A1C 7.9%, fasting 110, PP 205. Metformin plus sulfonylurea he has been put on. Now, this is a patient of type 2 diabetes with a high cardiovascular risk. Now, what are our major concerns here? Are we concerned about glycemic control? Are we concerned about reducing risk for micro and macrovascular complications? Do we want to prevent heart failure? Or do we want to optimize risk factors like A1C, BP, and lipids? Or the answer is all of the above. Obviously, all of you will agree with me, the answer is all of the above. So diabetes is a disease which is beyond being called a metabolic disease. And we know that it has got microvascular complications like retino, nephro, and neuropathy. And it has got macrovascular complications like atherosclerotic cardiovascular disease, stroke, heart failure, and peripheral arterial disease. What are the consequences if we don't bother to control the blood sugar levels? Let's look at the economic cost. The diabetes-related complications account for most hospitalizations, and it represents 55% of the total cost as per the type 2 Code 2 study in Europe. Whereas expenditure on oral anti-diabetic drugs and insulin accounted only for a small proportion of healthcare costs, that was 7%. The average annual cost of treating diabetes in India on a very, very conservative estimate is 15,000 per patient per annum. And people with complications spend up to 4 times more. And we know from the UKPDS data that every 1% drop in the A1C is associated with a significant reduction in the risk of 21% for any diabetes-related endpoint, 21% for deaths related to diabetes, 14% for MI, and 37% for microvascular complications. But we also know that there is no threshold of risk has been observed for any endpoint, which basically means that the lowest risk of complication would be those with an A1C value less than 6%. Now, we also know that reducing A1C reduces microvascular complications every 37% decrease for 1% reduction in A1C. Now, we also know that cardiovascular complications are the main cause of mortality in diabetes. Hyperglycemia has a causal effect on the risk of major cardiovascular complication because it is associated with low-grade inflammation and accelerated atherosclerosis. There is 4 times higher risk of coronary artery disease and stroke. For every 1% increase in the A1C, the risk of stroke goes up to 30%. 2/3 of deaths in type 2 diabetes are attributable to cardiovascular disease. There is 2 to 6 times higher risk of mortality from cardiovascular events and 2.5 times higher risk of developing congestive heart failure. And one should not forget the peripheral arterial disease. 1/3 of patients with type 2 diabetes over 50 years of age have peripheral arterial disease. So does intensive glycemic control reduce macrovascular complications? Now, what are the various variables that we have to look into when we are aiming for an optimal glycemic control? These are the patient characteristics like the age, duration of diabetes, comorbidities, hypoglycemia risk, life expectancy, whether the patient has established cardiovascular disease, what are the patient's preferences, resources, and support system. And then we have to have a target A1C. And this target A1C is our target A1C. What do we mean by our? We today, doctors are no longer gods. The decision has to be made in consultation with the patient. We have to involve and empower the patient to reach a decision at what target levels we want to set his A1C. We can only guide him. And then we have to see what is the best choice of an anti-hypoglycemic or anti-glycemic agent. And the ultimate goal is to reduce both micro and macrovascular complications with minimal risk of hypoglycemia. That is the utopian situation that we are aiming at. Now, we know all the drugs that are available. Is anyone superior to the other? Let's see. The results of various cardiovascular outcome trials imply that the type of drug used to achieve a glycemic control does matter because the total effect of a drug is not entirely conveyed by its effect on glucose levels. As a result, the diabetes field is moving away from its historical reliance on surrogate markers towards studies that assess outcomes such as heart disease and mortality to identify drugs that achieve the goals of diabetic care. Now, metformin, as I said, was the first drug to be studied in UKPDS, and it showed a cardiovascular protection, but it was based primarily on a very small group of patients. And there was 39% reduction in MI and 36% in the total coronary deaths. And this effect was sustained even though it was slightly reduced in the 10-year post-trial follow-up. And it was also said by the UKPDS group that since intensive glucose control with metformin appears to decrease the risk of diabetes related endpoints, especially in overweight diabetic patients, and is associated with less weight gain and fewer hypoglycemic attacks as compared to insulin and sulfonylurea, it may be considered as the first-line pharmacotherapy of choice in these patients. And today, it still remains the first choice. When we look at the various other trials that have been done for intensive glycemic control, we see a wonderful hazard reduction, a hazard ratio, and a reduction in microvascular endpoints. Now, there are three major studies, as you know, the ACCORD, the ADVANCE, and the VAC in older patients with diabetes with cardiovascular risk. Unfortunately, none of these studies, either individually or on pooled analysis, demonstrated any reduction in all-cause or CV mortality. Although the meta-analysis revealed 15 to 17% reduction in the incidence of non-fatal MI in those exposed to tight glucose control. And in fact, in the ACCORD study, higher mortality was observed and it was prematurely terminated. In another meta-analysis of major trials, 9% reduction of major CV events accompanied intensive glycemic control, but no significant effect observed on all-cause mortality or CV mortality. The possibility that late-stage high-risk patients may be less likely to benefit from glycemic control after years of hyperglycemia predictors was at that time entertained. And when we compare it, when we look at the microvascular outcome, as I said, but the macrovascular outcome benefit was seen only in the UKPDS study, that too in the late stages. So type 2 diabetes patients who received intensive glucose lowering therapy are associated with a reduced risk of MACE and MI, whereas it has no significant effects on the risk of total mortality, cardiac death, stroke, and congestive heart failure. And why is this? Let us look at the model of glycemic control and complications. We know with time there is a deterioration with the beta cell function and a persistent rise in the A1C. So if we start intensive therapy late, you're going to get complications, vascular complications at a higher rate. But if we start intensive therapy early on in the stage of diabetes, the complication rate will obviously be low. So what is the message that I want to give you here? Intensive glycemic control in patients recently diagnosed will greatly reduce microvascular complications. Intensive glycemic control in primary prevention of cardiovascular events is effective, but because of the low event rate, may take many years to document, as shown in the EDIC and UKPDS trial after 30 years follow-up. The benefits of intensive glycemic control on both the micro and macrovascular complication decrease with increasing duration of diagnosed diabetes and are possibly not effective after 10 years of diabetes. So we have had an evolution of guidelines. If you look at the post-UKPDS, we were glucocentric, then post-ACCORD, we became afraid of hypoglycemia and we wanted to avoid hypoglycemia. And post-EMPERX, we want to prevent cardiorenal complications, and the future is perhaps precision medicine. And that is how the guidelines evolved. If you look at this guideline of the ADA, it is if the patient has got ASFD or heart failure, you start this drug. So they are basically, again, complication centric. Again, the AC guidelines, independent of glycemic control. Don't bother about glycemia. If the patient has atherosclerotic cardiovascular disease, put him on an GLP-1 RA or SGLT2. And even if the patient has been drug naive, he has not taken metformin, he can still be put on this drug. So we have taken one area where we have become totally complication centric. So correcting the major metabolic abnormality in type 2 diabetes appears to have little effect on its major complications. So should we restrict ourselves to glycemic control only? If you look at this wonderful cartoon, if you lower A1C by 0.9%, the benefit per 200 subjects patient treated for 5 years is only 2.9% cases that you can save CV events. But if you reduce LDLC by 1 millipole milliliter, the same figure is 8.2. And if you reduce 4 millimeters systolic BP, the figure goes up to 12.5. So we have been barking up the wrong tree. There were other factors involved. And that takes me back to the famous 1002 study, which I think was a major milestone and is often forgotten. And it did talk about intensive therapy, but by intensive therapy, it meant dietary intervention and total fat less than 30 calories, exercise, smoking cessation, the use of RAS blockers, taking care of not only the blood sugar, but also blood pressure and lipids. And what happened? There was a 50% reduction in the cardiovascular events. And at 21 years follow-up of 7.8 years only of intensified multifactorial target-driven treatment with patients with macroalbuminuria, they showed that almost 8 years gain of life without the presence of cardiovascular disease. So the conclusion is that the optimal approach to the reduction of cardiovascular risk in diabetes should focus on aggressive management of the standard cardiovascular risk factors rather than only on intensive glycemic control. And one should not forget that this is a team effort. You have to have the various members of the team together to treat this patient of diabetes. So what are the key take-home messages I want to give you today? Friends, Indian Asian diabetics are essentially different from the Western population and require a more aggressive approach. Majority of patients do not reach the glycemic goals, whether it was ADA or RSSDI or whatever you want, because of therapeutic or clinical inertia. Knowledge about recent development in diabetes and newer drugs is very essential. We must set realistic targets and regularly monitor them, avoid procrastination, and attain target levels within a period of 3 to 6 months. That means hit early and hit hard. So there has been a paradigm shift in treatment. We should be more proactive and aggressive. Early combination therapy and timely insulin initiation. And most important, multiple risk factor intervention. So we should have a patient-centric approach and teamwork with involvement of the patient in his treatment. So let me leave you with some clinical pearls. If the duration of diabetes is less than 5 years, go for strict glycemic control when the patient is not having any comorbidities. If the duration of diabetes is more than 10 years, don't be very strict, have an optimal glycemic control, but become more complication centric. In between, it's a gray zone. You have to have an individualized approach. But above all, what is the most important is a holistic approach. Glycemic control plus hypertension, plus dyslipidemia, plus obesity, diet and exercise, abstinence from smoking, avoiding alcohol or drug use, and of course, stress control with meditation and yoga. And all of this should be the primary objective of diabetes management. Friends, it's time for all health professionals to treat diabetes aggressively. And it is also time for patients to take their diabetes with the utmost seriousness and not depend on the fake claims of drugs like BG34. And it is incumbent upon the healthcare system to provide the necessary resources for both to be successful. Then and only then can we beat the diabetes. Thank you for a patient hearing.
Thank you, Dr. Virmani, for your beautiful and very clear deliberation of the topic, that we should not be a glucocentric people, and we should go with the wider ramifications of the glycemic management, which you have clearly told us. If you have any question, I don't see any question in the chat box. So I think you have very clearly told us about the primary goal of the management in diabetes. So can I call upon my co-chairperson, Dr. Srinivas Murthy, to call upon the new speaker, Dr.
Yes, sir.
Akash Singh? And